Welcome, and thank you for standing by. I would like to remind all parties that your lines have been placed on listen only until the question and answer portion of today's conference. At that time, if you're wishing to ask a question, please press star 1 on your touch-tone phone, and please be sure that your telephone is unmuted and clearly record your name at the prompt so that your question may be introduced. Today's conference is being recorded. If you should have any objection, you may disconnect at this time. It is now my pleasure to turn the call over to Dr. Boland. Thank you. You may begin.
Thank you very much, and welcome everyone today to our STD Prevention Science Series that is co-sponsored by the American STD Association and is being held here at CDC. So we're very excited to have Dr. Ada Adamora here today. Those of you who don't know her, she's a professor of medicine and epidemiology at the University of North Carolina in Chapel Hill. She has over 20 years of experience working in the field of STIs and HIV. And as Sevgi likes to describe, she has helped characterize the epidemiology of heterosexual HIV transmission among African Americans and has highlighted the role of sexual network patterns in the spread of HIV and underscored the importance of macroeconomic and social forces in racial disparities in the United States related to the HIV epidemic. So we're privileged to have her. Just to let you know a little bit about her background, she got her MD at Yale, trained at Boston City, and interestingly, first started her career as a physician at Harlem Hospital and then actually worked for the North Carolina Health Department and then decided to move over and make a commitment to her career in the field that she has led for quite a number of years. She actually has a number of prestigious positions right now, so always good to introduce yourself afterwards if you haven't had an opportunity. She chairs the HIV Medical Association group and also the NIH HIV Prevention Trials Network for Women at Risk Committee, and is also a member of PACHA, which is, if you don't know what that stands for, it's the Presidential Advisory Council on HIV and AIDS, and we recently just had a joint JAC meeting with PACHA, so actually it does very important work for our field, not only in terms of research, but in terms of sort of leadership and policy. So, Ada, we're great to have you. The title of your talk is Public Health in a Hostile Environment, Racial Inequality and STD/HIV in the United States. You've got your clicker.
So thank you very much for that introduction, Gail. And thank you for asking me to speak. It's really a pleasure to be here. I'm going to be talking today, well, you see the title, Public Health in a Hostile Environment. I was actually thinking of calling it Through a Glass Darkly, but then I sort of changed my mind. But I'm mainly talking about racial inequality and STD HIV in the U.S. I have to admit, I know that you're the STD group. I'm mostly talking about HIV, but, you know, HIV is an STD, so, and a lot of this applies. So the problem, here's how I decided to frame it. So the problem, African American and HIV STDs. I think, we have excellent understanding of pathophysiology, of behavioral and other individual level determinants of HIV and STIs. But in fact, at least it seems to me that we have relatively little knowledge of population level determinants and even less knowledge about population level interventions. And so actually what Sevgi had asked me to talk about was what are the challenges, particularly the methodologic challenges in evaluating social forces and contextual factors that affect population HIV outcomes. So I'm going to be talking about concurrency, a little bit about mixing patterns on a very simple level because that's how pretty much my mind works. And I have to admit, I'm going to be mainly talking about my work. A lot of people have done a lot of extraordinary work. I'm just trying to look at a few examples and just talk about what I've done, what I know best. And forgive me if you all, I know this is the STD branch and you all already know all this, but I'm just going to try to highlight a few things. So I'm going to start out talking very briefly and giving an overview of some important network and partnership characteristics in populations that are at increased risk for HIV and other STIs. And then talk, and this is actually somebody else's work, talk about methodologic challenges in evaluating the role of social and contextual forces in disease outcomes. And then finally look at an example where we tried to do a contextual analysis of concurrent sexual partnerships. So as certainly all of you know, Network and partnership characteristics are critical in the spread of HIV and other STIs. And some important, these are not the only ones, but some important network characteristics are the size of the network, the connectivity of the network. In addition, the extent to which it's assortative or disassociative, like with like, or people of unlike or dissimilar risk mixing. Partnership timing, for example, concurrency. And not just whether or not there is concurrency, but how much overlap is there? How long does the overlap last? And what is the nature of the networks anyway? And also the prevalence of STIs that can promote HIV spread. What's the prevalence of HIV itself? What's the prevalence of other STIs? And what's the prevalence of even BV, which is strictly speaking not an STI? Then important partnership, the characteristics of the partnership are, again, once again, the timing. Even if they're sequential and not overlapping, what are the gaps? How long are they? Short gaps promote STI spread more readily than very long gaps. What type of sex are people having? And obviously how many partners, but what type of sex are they having? Are they using condoms or not? And how infectious is their partner? These are just some, but not even all, obviously, of the things that are important in spread of STI that relate to partnerships and to networks. But a big challenge is that these data are very seldom available in one data set. At least in my observation, it's not that common to know people's coital frequency and all this, and have all this information in one data set. You have some, but not all of it. So looking first at concurrent partnerships, and this is certainly not the most important characteristic, network pattern, but using an example of something that I and many other people have looked at. So as you know, and you're sort of trying to point this out down here, in this little picture, this is, these are partnerships that overlap in time, and they can enable faster spread of infections through a network than the same number of sequential partnerships, as Martina Morris and Kretschmar and all, many other people have demonstrated. Concurrent partnerships are associated with transmission of chlamydia, with syphilis, and also with HIV. We showed that in our study. I will say that there's been a lot of debate about the importance of concurrency in HIV transmission in Africa. Really very hot debate. But interestingly, there's been less active debate about the role in heterosexual transmission among African Americans, which I find to be interesting. So just to briefly review, there are a number of things that have been consistently shown to be correlates at the individual level of concurrent partnerships. And among them, among the big ones, at least to me, are, marital status, marital status, age, early age at first sex, substance use, partner incarceration, a partner with concurrent partnership. These are all associated, not necessarily causal, but they're associated. It has also been demonstrated that the prevalence among African Americans has been higher overall among whites. However, when you adjust for individual correlates, especially marital status, this has tended to substantially decrease the association between concurrency and race. So that's one overview. Irene Doherty, several years ago, mentioned that duration of overlap is important, and also whether or not people use condoms. I mean, if people are always having protected sex with every partner, then it really probably doesn't matter if they have concurrent partnerships. And also, as I mentioned, the duration of overlap matters. And what she looked at this in the National Survey of Family Growth. I think this was in 2001. And she found there was considerable diversity in the amount of overlap. This is among men who were in that survey at that time for the first time. About a third had an overlap of less than a month, 19% for 1 to 3 months, but about a quarter had an overlap of more than a year. Now, concerning condom use, again, this matters, whether or not you use condoms. No condoms were used for last sex with either partner in more than half of the concurrent partnerships that she looked at. And interestingly, it was white men who were the most likely to have unprotected sex. Black men actually were most likely to have had protected sex with their last two partners. White men were the reference here. Married men also were unlikely to have, were least likely to have protected sex with their last two partners, saying something about the risk to their wives clearly and to their other concurrent partner. So what about mixing patterns? Irene also, getting started with this. So just a little about mixing patterns. We know that this is important. Assortative mixing, this is again for definitions, partnerships between people who are at similar risk for infections, at least for the purposes of this discussion. And that tends to keep infection within the risk subpopulation. If you're a drug user, you only have sex with people who inject drugs, you're going to keep it within that population. Most social and sexual networks are relatively assortative, relatively. Disortative mixing, on the other hand, is, again, for the purposes of this discussion, where people at high and low risk for whatever characteristic is of interest form partnerships. This tends to disseminate infection throughout the population. A number of years ago, Ed Lauman at University of Chicago and Yusuf Hume looked at mixing among African Americans and found that there was more frequent sexual contact between individuals with many partners, that is what was called the core, and those with few partners. Again, disortative mixing within race, but also found that sexual networks, at least at that time, were relatively segregated by race. So a tendency or a bit of a move toward an explanation for how infection might spread within a race and potentially stay there. Irene, again, looked, when we worked together, looked at mixing patterns among African Americans in North Carolina. And this was in the context of a case control study that we did a number of years ago. And it was a study of risk factors for heterosexually transmitted HIV infection among African Americans in North Carolina. And what she did was she used a mixing coefficient to quantitatively estimate the extent of mixing among our case control respondents. And what she did was that she compared control men, and I apologize, here are controls or men over on the left side of the graph over here. And she compared control women, right? So control men, control women are over here, and HIV positive men and HIV positive women concerning mixing with respect to education, incarceration, drug use, and concurrent partnerships. And the upshot of it was that the male controls, who usually were pretty low-risk people, I mean, these were the controls of people from the North Carolina general population. So these were pretty reasonably low-risk people. Male controls tended to have low-risk partners. But interestingly, women, who also were pretty low-risk people, had substantially more discordant partnerships with respect to incarceration and the education of their partners. So they were sometimes higher educated people, but their partners had lower education. And not surprisingly, they were unlikely to be incarcerated, but the partners, given the prevalence of history of incarceration among black men, were very likely to have. So this isn't that surprising, but notable anyway, I think at least, in sense of trying to understand who's mixing with whom, or to get a sort of a glimpse at that. So then there's another issue of what are partnership patterns like among women at high risk for HIV and other STDs. This is HPTN 064, which was a longitudinal cohort study, a multi-site study among roughly 2,100 women in these sites here. Mostly, it was entirely in the eastern part of the United States. One site was here in Georgia. And enrolled, and Anne was involved in this also, enrolled women who were 18 to 44 years old. And they had to be HIV negative, at least not know themselves to have HIV infection. This is from 10 urban or peri-urban communities in the Northeast or the Southeast. And the key issue was that they had to reside in areas with high HIV and high poverty rates. In addition, they were required to have at least one high-risk personal or partnership characteristic. For example, at least one episode of unprotected sex with a man in the past 6 months, or at least one additional personal or partner HIV risk characteristic. And actually, it turned out that the annual HIV incidence in this population was fairly high. It was 0.32%, which is considerably higher than what CDC estimates for the general population of black women. So these were relatively high-risk people, as was the intent. So we did a sub-analysis of this and looked at characteristics of multiple and concurrent partnerships among these particular women and found that, and so here I'm going to distinguish between participants' concurrency, as I have concurrent partnerships, versus partners' concurrency. My partner has concurrent partnerships. So that's an important distinction, not to get confused about what I'm talking about. So mine, my participants, or partners. And so the prevalence in the past 6 months was high, as one would imagine, given the risk characteristic was 40%. And a third of women roughly said that they believed their partner had concurrent partnerships, and they believed this very strongly. They were pretty certain. I definitely did. And then a quarter said that they both did it themselves and their partners had concurrent partnerships. So we looked at the overlap in partnerships among people who had concurrency themselves and among people who had concurrency and whose partners had concurrent partnerships. And it was 5 months with an interquartile range of 16 versus 1. So there's some non-trivial amount of overlap. Among women who had more than one partner but who didn't have concurrent partnerships, the median gap was only 1 month, which is quite short. I mean, it's actually quite short, and what you could imagine. You don't think so, Matthew? You disagree? Oh, okay. I thought you were disagreeing with me. You can if you want. I mean, it would allow transmission of a goodly number of STDs. And so we see what I guess I would call a significant amount of overlap. We looked at some other characteristics of their partnerships as well. Now, you may not be able to see it, so I'm going to read this. So this top line is just looking at the characteristics of their most recent partnership. And they reported on, I think it was like 3 within the past 6 months. And so the question is, well, what is the coital frequency? Well, I don't know how much you can really expect people to remember about the number of times that they had sex, depending upon how memorable or not memorable it was. But, my thought was, you should be able to tell whether you had sex with this person, just a couple of times or more than 10 times. I mean, I think a reasonable person could be expected to remember that. So that was my push for what I wanted to see here. Again, and these columns are my own concurrency, my partner's concurrency. This is my own concurrency only, but my partner, I don't think this guy did. This is, well, I know he had other partners, but I did not. This column of both is, I had him and he did too, and this partner is, I didn't and I'm sure he didn't. I don't believe he did either. So we see here that people had sex, they reported having had sex without a condom a fair number of times, generally about half of people in all categories during the past 6 months. There's a chunk who had anal sex also. I'm not sure they had it a whole lot, but it's a good 10 to 14% or so reported having had anal sex several times, between 2 and 10 times during the past 6 months. In terms of their knowledge about, this whole push for having people know whether or not their partners have HIV or at least have been tested, there's a good chunk, at least 35 or so, 30 to 45 or so percent either said he has not been tested or I simply don't know. Many of them did know, but a lot of them didn't. There was not much drug use of partners on the part of partners in this particular cohort. Now, it is notable, though, that about 2% of women believe that the most recent male partner had sex with men. So there's a connection to another network there. In this one, we looked at women who reported 2 or more recent partners. And so this is a little trickier understanding this. So we asked them the frequency, again, we're trying to get at this issue of coital sex. Okay. The frequency of coitus, rather, in the past 6 months. And here we're looking at the differences in these same columns between people who had vaginal sex with at least 2 or more partners on more than 10 occasions, or really just a few occasions. And interestingly, the people who were involved in some fashion with concurrency actually had sex more often than with both of these partners than the people who were not involved in either of these partnership patterns. I bring this up because this has been argued by people who do not believe concurrency is important. One thing they talk about is coital dilution. It's not meaning that people, if they have multiple partners, they're not having sex that often, or as often as if they only had one partner. And it's not apparent to me that that's necessarily true. Then we looked at the same question, but have you had vaginal sex without a condom? And once again, we see that people who are involved in some fashion with concurrency were more likely to report that than people who were not involved with concurrency in any fashion. Moving down to their knowledge of the partners, once again, the people in this it's a very high-risk population. The people who were involved to any degree with concurrency were more likely to say that the partner hadn't been tested or she just didn't know than those people who said, well, I'm not doing it and he's not doing it either. And I'm sorry, in terms of how we defined the individual's concurrency, we did this by comparison of dates. We didn't do it by just asking them for this particular analysis. This is a different study, and this was actually done in cooperation with the CDC. And this was a cross-sectional survey of about 1,000 black women between the ages of 18 and 59 in 2 counties in Alabama and North Carolina. And these were regular women from the community. The only thing that they had to do was a cross-sectional study. The only eligibility criteria were that they had to have had sex with a man in the past year and not know themselves to have had HIV infection. They were, however, very poor. 49% in the convenience sample, 49% had household income less than $12,000 per year. The median number of sex partners in the past 12 months is pretty similar to the general population, was 1. In contrast, what I didn't say in HPTN 064, it's my recollection that the median number of partners in the past year or whatever the time period of interest was 2. So one thing we were interested in here was looking in a little bit more depth at partners concurrency, what I call indirect concurrency. And you can see here that the prevalence of participants concurrency is actually substantially lower than it was in the previous study. It's really not that high. This is in the past year, although the other studies past 6 months, 14%. Partners concurrency is 10% alone. 10% of people had both concurrency themselves and believe their partners had other partners and believe that strongly. But most of them, about 2/3 said, neither. I don't do it, he doesn't do it either. Again, these were comparisons by date, so it was not actually a direct query for this analysis. One of the things that we were interested in was in looking and see what things correlated with partners concurrency. What are the associations with who's most likely to be in this situation? And actually nothing really correlated except for 2 things that both involved violence. And one of them, and this is this last category here, the second column here all the way on the right, partners concurrency. You can see that, we were wondering about whether a history of either sexual violence or intimate partner violence correlated with it. And in fact, it did, with a prevalence ratio of 1.65 and 1.62 for forced sexual contact ever. Another thing that people have wondered about is what motivates people or it may not be motivates, but what allows them to be in this situation. Because most people, when you ask, say that they don't like it, that their partner has other partners. There are some people for whom it's an arrangement and it's fine, but in general, people aren't really crazy about that. So one question is, well, why are you staying in it? Surely you must be getting something out of it. Something must, maybe you can't afford it. Maybe it's all the best you can do. We actually did ask them this stuff in anticipation of this analysis. And it turns out, and I would draw your attention to this bottom section that unfortunately I guess you can't read. So what it says, and I apologize for that, if this is, your partner has given to you or your family any of these things: money, place to live, food or things for the house, clothing or gifts, paid bills, drugs, or maybe nothing. Well, it turns out that the people who were in this relation, again, this is individuals concurrency, partners concurrency only, both, and neither. In fact, the people who are in the category of neither, whereas they don't believe the guy has other partners and they don't have other partners themselves, they were generally more likely actually to be receiving something than those people who were in the concurrency category, which was sort of interesting to me because I was sort of assuming, well, the only reason you're putting up with this is because you're getting something out of it. Although I guess if you look at it a different way, maybe the relationship is a less clearly defined one, so why should you be getting anything? So I don't know the reasons. We didn't ask them the reasons, but this is a correlate. The upshot being, again, mutually monogamous partnerships were actually more likely to be associated with receipt of material goods. So many people have done qualitative work related to concurrency, and Pamina Gorbach has actually done some very interesting work. What we did when we were looking at our same North Carolina population, what we found that people talked about related to not just concurrency, but sexual network patterns and what it was like to be living in their community. What they described actually was pervasive economic and racial oppression, lack of community recreation, boredom, and resultant substance abuse. They really talked a lot about a shortage of black men in general, and particularly a shortage of what they called, people who were making any money that they wanted to be with. And they attributed themselves to higher mortality and incarceration rates. And they did talk about widespread concurrency among unmarried people. They were not saying that there was, at that time at least, this is a long time ago, they weren't talking about concurrency among married people. But we concluded, given their description of the situation and the pathways that they talked about, that contextual features may promote sexual patterns that transmit STIs, including HIV. So just to summarize, just some sort of general summary from what I've talked about so far, short gaps between partnerships among some women who are at very high risk for HIV, remembering that that was sort of a rarefied population. Most black women are not like those women in 064. But the short gaps between the partnerships among those women, some who were at increased risk for HIV, are probably among the features that can promote STI HIV transmission. Distortative mixing there is some evidence of that. Not great evidence, but some evidence. There is a little bit of mixing between populations with extremely high HIV prevalence, like MSM, and I didn't talk much about that except for saying that in one of the studies, which actually it was the HPT and 064, about 2% of women did mention, it's not very much, but given the network characteristics that we observed, some of these connections could also promote, between these high-risk subpopulations, could promote dissemination of HIV and other STIs. We also saw, and I didn't dwell on this, but we consistently noticed this, people who have concurrent partnerships are very likely to have non-monogamous partners, I guess for obvious reasons. If you're doing it, this other person might too. Suggesting, although certainly not proving, but suggesting the presence of relatively dense networks. So it's not just like polygamy, where you have, a man with multiple wives or a woman with multiple partners, and infection's really not going to go anywhere outside that little network. This suggests something else, what we observed. It's me. And finally, many of these network characteristics facilitate spread, especially in high-risk subpopulations where there's a higher prevalence of STI to start with or a higher prevalence of HIV to start with. So what Sevgi actually wanted me to address is some of the methodologic challenges in evaluating contextual effects on STI outcomes. And so for that, I turned actually to somebody else, Anna Diaz-Wu, who wrote what I thought was a great paper. And I'll just mention what I thought are some of the things that apply to the situation we have at hand here. So one question is, how do you even define, and this is the idea of, the repeated observation that neighborhood characteristics / social forces clearly do affect people's sexual behaviors, and they can certainly affect their sexual network. So one question, if the neighborhood is the exposure or the thing of interest, how do you even define it? Or if it's not a neighborhood, what is the relevant geographic area? And an issue is that the definition of the neighborhood or the area whose characteristics are relevant to whatever your outcome of interest is, the definition is often imprecise. The definitions can be based on people's perceptions when the area characteristics sort of relate to social interactions. The studies that we often do, though, are sort of they involve administratively defined areas, which is reasonable if the processes involve policies. The policies that you're interested in are decided perhaps at the county level or whatever level. That makes sense. Geographically defined areas are important to use when features of the physical environment are important. In any event, the size or the definition of the neighborhood, the relevant processes, and the outcome are all linked. And these ideas are all from Anna Diaz-Wu. This is it from AJPH. One thing that we tend to do is that large quantitative, when we do this research, many people do this, large quantitative analyses rely on existing administrative definitions for which the standard data are simply available. I mean, that's what we have, what we can use. They're available so that individuals and other sources of area data can be linked to these data. A difficulty with that, though, is that these areas may not necessarily correspond to the theoretically relevant area. So you can do it, but that may not necessarily be the area that makes sense. And a corollary of that is that specifying the relevant area characteristics can also be a bit of a challenge. And it's pretty complex. Many characteristics can be related, and they may also influence each other. In addition, the processes, as you would expect, the processes involved and the relevant attributes may differ from one outcome to another. So, for example, the physical environment is important if you're looking at physical activity. Social norms of contagion are important for things like drug use and smoking. In addition, measuring these areas, not just defining them, but measuring these area characteristics can be complex. And the options include surveying residents, but that takes money, and you have to get, there are always issues of defining who you're going to survey. Direct observation, there have been people like, I think it was Sampson at the University of Chicago, who drive around looking at the neighborhood and defining it. Now, if you want to do a study in the United States, but unless you're going to use Google Maps, that's not too easy to do. And you can also, again, use these linked databases with geographically linked information from public agencies. What about the role of individual level variables? How exactly should they be incorporated into models and into analyses? And some of the ways of doing this and demonstrating an effective neighborhood or area context on a health outcome, or, among them are the stratification, multivariable adjustment. But a thing to note is that the relationship between area characteristics and individual level socioeconomic status is also complex. For one thing, individual level characteristics can be mediators, since neighborhoods can influence health through their effects on income, education, certainly where you go to school, occupation, whether you can get to work from wherever it is you live. In addition, residential segregation occurs partly via socioeconomic position. So living in a disadvantaged neighborhood may be one of the mechanisms leading to bad health outcomes among low SES individuals. In addition, your low SES is what can get you into the neighborhood. Finally, neighborhood and individual characteristics, again, this is sort of reiterated, can mutually influence each other. We know, of course, that disease is expressed at the individual level, and whether an individual variable is a mediator or a confounder depends on the question that's being asked. Teasing apart so-called independent effects of some neighborhood and individual characteristics, although it's useful analytically, really can be somewhat artificial. So, for example, if you look at, I was in a discussion with people a few weeks ago where they were looking at the effects of, it was food insecurity. And so what was being requested was, well, did you control for income? Well, so, you know, and if you wanted to, under what circumstances in the United States actually are you likely to be food insecure if you have a high income? Now, you could be, it was pointed out to me when I raised that, well, if you're looking outside the United States, that's actually a valid question because you could be food insecure because of drought or some disaster. But here, not so much, I don't think. Not likely. Study design considerations. So quantitative studies can be used to allow examination of within and between neighborhood variability in outcomes and factors that are associated with them. It's a good idea to have sufficient numbers of neighborhoods and also sufficient numbers of individuals per neighborhood. Another interesting problem, which we'll get to in a second, is having enough ranges in the types of neighborhoods. Again, you can use census data or other linkage to other sources, crime data, et cetera. And combinations of quantitative and qualitative approaches. Qualitative studies actually can be very helpful in figuring out the processes that are involved and sort of dynamic interactions between area and individual characteristics. So in our conceptual model here, what we use, a number of powerful social forces. We're looking at concurrency. A number of these powerful social forces work separately and then together, just as Anna Diaz-Roux was suggesting, to influence sexual networks. And we were going to focus on poverty and the low sex ratio, particularly the low sex ratio. We've seen that the strongest correlates really consistently of concurrency among African Americans is marital status. And it's known, the problems of marriage has decreased among, everybody. But in particular, marriage rates among African Americans have been strikingly low compared to other racial ethnic groups. And it turns out that the low sex ratio has been one of sociologists' main explanations for the decreased marriage rates among black people in the U.S. It may also increase bridging between low-risk women and men from high-risk subpopulations. That disordered mixing I was talking about before. Sociologists have also postulated that another reason for blacks' low marriage rates is poverty, which further decreases the pool of economically viable men and destabilizes marriages. So it turns out that these focus group residents that I was talking about, these respondents that I was talking about, were right. And this is from the census from a while back, and there are better displays of this. This was talked about in the New York Times actually pretty recently. The sex ratio is substantially lower among blacks than it is among whites. There's no question about it. And in fact, it's further decreased by, it's not only black male mortality due to various types of violence and disease, but it's further lowered by disproportionate incarceration of men. This right here is the absolute sex ratio before you account for incarceration. So, given the association between concurrency and marriage, we asked, can we quantify the relationship between the sex ratio, community poverty, and concurrent partnerships among U.S. men and women? So our conceptual model for this particular study was actually derived from several things: social exchange theory, the work of the sociologist William Julius Wilson, and also Marcia Gutentag and Secord, and then also a model used by John Billy, Karen Brewster, and other people. So this is derived from sociologists. And in our model, neighborhood characteristics that you see listed there influence individual participation in concurrent partnerships, basically by creating an opportunity structure that increases the likelihood of various behaviors and factors that are associated with concurrency. So neighborhood variables presumably affect concurrency through these individual level characteristics like marital status, substance use, et cetera. And so I'll stop there, basically. That's the model. And so our hypotheses were that involvement in concurrent partnerships is related to economic, social, and demographic characteristics. And secondly, that adverse community characteristics will largely account for the racial differences that we observed in concurrency. We saw that actually when you adjust for the individual level characteristics, racial differences did markedly decrease, particularly among women. Our source was your data, the NCHS data, National Survey of Family Growth, which you know about. And this was the 2000 cycle, in which there were 4,900 men roughly and about 7,600 women aged 15 to 44. Blacks and Hispanics and teenagers were oversampled, and they used CAPI and ACAPI to survey people. The contextual database that went with it, I don't know if they're continuing to use, I hope they're still doing this with the contextual database, but the contextual database was from 2002, and it provides characteristics of communities. These so-called contextual variables were NSF2 respondents. And the sources of the contextual data file were the census file, and also the county and city data book. And the primary outcome that we were interested in was the presence or absence of concurrent sexual partnerships with people of the opposite sex in the 12 months before the interview. And what we did, again, was a states method comparing the dates of first sex with one partner and having to occurred 1 month or more. Actually, it was more than 1 month before the last intercourse with an earlier partner was the definition of concurrency. Our exposures were well, our exposures were two things. As I mentioned, the sex ratio, which is the number of men compared to the number of women among 15 to 44-year-old county residents and the respondents' racial or ethnic groups. And this was actually fairly hard. We compared a low sex ratio that is less than 0.9 to a balanced sex ratio, which was 0.95 to 1.05, instead of making it a continuous or ordinal variable, because we wanted to evaluate the effect of a low sex ratio compared to a relatively balanced sex ratio that exists for the overall U.S. population of reproductive age. The second thing was the percent of respondents' rates in poverty where they lived, that is, a proportion of the county population in the respondents' racial ethnic group with a 1999 income that was below the federal poverty line. So we included all these individual level variables that you see in this slide because we had seen that these things were associated with concurrency before. And the contextual variables operationalized the concepts in our model. We put in crime because we wanted to use this as sort of a marker of community disorganization. And what we did is that the NCHS, the RDC merged the requested variables, and then we submitted the statistical program to them via remote access. And we examined first the individual level variables and their association with concurrency, then next the contextual, then we combined the best individual level and contextual models. And we used their weights, NCHS divided weights. So, as it turns out, this is what it looks like overall. The median, here we see in the middle, I'm a little sort of like spastic when it occurs. The median respondent lived in a census block group, lived in an area where the median household income was $42,189, the sex ratio was 1, and the percent of the respondents' race in poverty was 9.8, and that was the violent crime rate per 100,000 person years. And this shows the crude and adjusted prevalence odds ratios for concurrency for these individual level variables. And so it's the individual level things is the same as what I talked about before. And again, in the adjusted analyses, marital status remains the strongest correlative concurrency with odds ratios of about 5.8 for unmarried people. And substance use and age of first sex are essentially unchanged. This is what we've typically seen. Now, as for the contextual variables, here we have first crude and in the middle and then adjusted on the right. Low sex ratio and poverty in the respondents' ethnic or racial group were associated with the higher crude concurrency prevalence, as in fact was violent crime. In the adjusted analyses, the association between concurrency and low sex ratio did decrease, and association between respondents' race and poverty and violent crime also decreased a little bit, and all associations became less precise. In multi-level analysis, which was in fact the point, the association between low sex ratio and concurrency actually increased and was significant, we say 1.67, and other associations were essentially unchanged. And again, they all were in the same direction that they'd always been before. So one thing, if you remember, is I'll go back. So one thing that was to say, well, do these adverse characteristics, low sex ratio and poverty, can you explain a lot of the increase in the concurrency among black people, the increase of rates? Can you explain this by evaluating these two things? So one thing that we did to start with was to look at the county sex ratio distributions of respondents by race ethnicity. Low sex ratio, less than 0.9, is in blue, and the balance is in black. And as you can see here, only 1% of whites and 8% of Hispanics experience a low sex ratio. In contrast, the black sex ratio is the mirror image. Only 8% of blacks experience a balanced sex ratio. There were also very dramatic differences across racial ethnic groups in their exposure to poverty where they live. Not necessarily their own, but their exposure where they live. And here we see that for 5% of whites, about half of Hispanics, and about 3/4 of blacks lived in counties where more than 1 in 5 households in their own racial ethnic group was below the poverty line. So in summary, the low sex ratio was associated with a higher concurrency prevalence. The percent of respondents race in poverty was also associated with a higher concurrency prevalence. But the marked restriction of range in racial distribution of sex ratio limited our ability to assess relationships between race and concurrency. Now, other people have looked at this also, and one was Enrique Puget. He used a different data set, but it is also Ben Haynes sampling the United States, as you know. And he was looking, and his question was, are the sex ratio and the incarceration rate associated, not with concurrency, but close, multiple opposite sex partners in the past year? And what he found was that non-Hispanic black men, I just copied this particular graph, in counties with a greater male shortage, and I would pay attention to the matched sex ratio, and with more incarcerated men, you can see these rates go up dramatically, had a greater odds of having at least 2 partners in the preceding year. So again, you know, it looks to me as if there is some association with higher concurrency prevalence and low sex ratios, and certainly with community poverty. But it is the major thing that I draw from this is that the differences in the context of life between blacks and whites in the United States are so very stark as to preclude a direct test of whether sex ratios or community poverty can explain racial ethnic differences in concurrent partnerships. So how I would sum this up is that the social and economic context in my view, very clearly does affect sexual networks, which in turn affect population levels of HIV and other STIs. Studying the social and economic context is somewhat outside the current STD, HIV epidemiology paradigm, and it's certainly associated with challenges. I mean, we ran into them. We couldn't find enough differences in the context to do the study. But finding a way to do this is important to affect changes, I think, in rates of STDs and HIV. And on that note, I will say thank you very much for your attention.
Left us with an important challenge. So we'll see if there's questions from the audience, and we can also open up the phone line. So
Thank you.
I really enjoyed the entire thing. So I have a question about, I was really surprised by the first study that you were showing where the people who were experiencing neither type of concurrency were more likely to be in a transactional relationship. They received goods, drugs, whatever, money. Was that, were the people who were receiving goods or the people who were in neither type of concurrent relationship, what was the duration of their relationship? Was there an association there? Where there was longer relationships?
I don't know. I honestly can't answer that. And I personally don't look at this as they're receiving. I mean, I guess they still are, but I don't look at it that way. They're receiving goods and drugs and whatnot. How I look at it is, I mean, isn't that why you get married? I mean, it's
well, that's why I was asking about the timing.
I mean, you're supposed to be getting something. Why? Perhaps you should reevaluate if you don't. So that I don't look at it as being, like people are trading sex for drugs, unless it depends if you may be sort of a very politically, say, well, that's what marriage is. It's a big economic transaction, which it sort of is. My only point being that this sort of assumption that at least I and many other people I think have, oh, they're staying in this because they're getting this specific thing, is something that should perhaps be thought of again. And again, I don't know that everybody is like these people. This is one study, maybe something else was with you. So I just want to clear that up. I'm not trying to say that I thought these people were.
If we do have parties on the telephone lines wishing to ask a question, please press *1 and record your name clearly at the prompt. Again, it is *1 if you wish to ask a question.
And if you're in this more nebulous relationship where, it's not you doing whatever and he's doing whatever. I don't know if that's
okay, so just independent of transactions, what do you think is the distribution of duration of each type of partnership? Between the four types of concurrency, between neither and then both and then the, positive with one or the other?
I'm not sure. Those people in that study, the only thing, we had some disagreement about how high risk these people were in that study. This was not HPTN 064. This is the women in the rural South. And in fact, I don't know the answer to your question. It's a short thing. But I will say that there was a higher prevalence of history of having had anal sex. But really, the people didn't look particularly high risk to me. They didn't have very many partners. If you saw, the prevalence of concurrency wasn't that high. Most of them, almost 2/3 of them said, well, we perceive ourselves as being in stable relationships. So I'm sorry, it's not a direct answer, but that's all I can say about them right now without doing the analysis again.
Anna, thanks so much. There's a lot of thought-provoking information that you've just given us. I would agree with you that there might be more of a quid pro quo sort of exchange relationship among the lower, among the other groups than the neither concurrent group. And in fact, there's a lot of discussion of that in the qualitative data from 064.
You're saying there's more quid pro quo? Because I was saying that they didn't seem to be getting that much, is what I was saying.
No, I'm talking about the nature of the exchange, not the amount of the exchange.
Oh, okay.
Yeah. So we had women in 064 talking about how, if I don't have enough money, I've got like 3 guys, I'll call one of them and see if they want to go out tonight. But the other thing I've been wondering about is whether the shortage of men also influences the disorderage of mating. In other words, if there aren't enough men around, you might lower your standards for who you're going to go out with. And if that were the case, that would be evidenced by the fact that women would tend to be in a higher SES or similar category than men in cases of disorderage of mating. But also, is there a way to disentangle the effects of those two things? Because both of them should confer some risk.
Mm-hmm. So yeah, I may not have been clear about that. I do think that the low sex ratio increases the likelihood of more disordertive mixing. I do believe that. And my evidence for it is that Irene Doherty study where she actually, but I must say it's not an analysis of both the sex ratio and the disordertive mixing in the same data set. So I'm sort of inferring this. I don't know if I'm correct. But she did show that women were interacting with men with lower education and with, prison records and whatnot. So there's that. Also what people say. I mean, people say this all the time. They just come out and say it. This is you men, and so this is what happens.
Thanks. That was a great talk. My question is about the measurement of partnership perceptions of concurrency, and I'm wondering if there's any data that validates whether or not the index's perceptions of their partner having other partners is in alignment with the reality, and whether or not there's some reverse causality in some of the findings you had where folks maybe who are in an abusive relationship perceive themselves at a lower standard or sort of perceive themselves at a lower level and assume that their partner has other partners when that may not actually be the case.
Yeah, that's a good question. There actually are data that look at that, and I can't remember the references off the top of my head, although I could probably find it for you because I referenced that in writing those papers. And people are not that accurate in knowing whether their partners have other partners. However, in at least one study that I've seen, when the direction in which they err is in believing that the person is faithful when they're not. When they think that the person has another partner, they are often likely to be correct, although not always. Sometimes they're just paranoid. I mean, but that's the direction in which people err is in terms, according to this one paper. The other thing is, when we did this intervention, it's what you said on the flyer I was going to talk about, by then I didn't have time. And we did these focus group responses. It was focus groups related to, concurrency, and just so that we could create these ads. And people said some interesting things about how they knew what their partners were doing. And one way that they know is because sometimes a person will just tell them. I mean, that's the nature of the relationship. They may have gotten an STD, or the person may have gotten pregnant, or there's the internet, Facebook. People put this stuff on Facebook. Oh, guess who was at my house the other night? I mean, people could be lying. They're not necessarily filming it, but, who knows? So there are a lot of ways. And the other thing, the final thing I'll say is that we had different categories of the question, like, well, you think he definitely didn't do it? Do you think he might have done it? Do you think he probably did it? Or do you think he definitely did it? And the one that I would always analyze is definitely did. I wasn't interested in just the paranoid people,
Actually, you touched on part of the question. I was going to ask the role of social media, maybe in either of the studies with technology that's out there, like you said, Facebook, Tinder, all the other modes. But thank you for mentioning that. I guess the other part, and I apologize if I missed this, but did any of the subjects, specifically the women, I believe in the Alabama and North Carolina study, identify any interracial dating or maybe the mixing or concurrent relationships interracially, or did they stay within their race?
So both of those questions, actually, the last two questions were asked by reviewers of the paper. And I actually am pretty sure, and the person who's doing it, Christina Ludema, is a fellow who's doing it, and she's actually going back to look at the whether it's interracial dating. I don't think there was much, and mainly because of the demographics that the people were in and the rural counties that they were in. It's not like this was like metropolitan Atlanta or New York or San Francisco and these people were, you know, and it wasn't college campuses. So I don't think there was much. I do know for a fact that in our earlier study of, you know, the heterosexual risk transmission among African Americans, this was a while ago though, in North Carolina, actually various counties in North Carolina, there was very, very little interracial dating at that time. And we did ask the race of the partners. So she's looking at that, but I really don't think there was much in those counties. Not that there isn't. I mean, there is a lot of interracial dating and interracial sex. But given the demographic and the characteristics of the people, I think that was extremely unlikely. But we are looking for certain.
I know we're running out of time. Could we try to open up the phone line just to see if we have any questions on the phone? Operator?
Thank you. And if we do have parties on the telephone lines wishing to ask a question or make a comment, please press star one. Again, it is star one to ask a question. One moment, please.
Do I assume that is a no, operator?
At this time, I'm showing no questions.
Okay, well, thank you very much. We'd like to conclude the session. And again, thank Ada so much for the excellent discussion.
This does conclude today's conference. Thank you so much for joining. You may disconnect at this time.